welcome everyone to the first edition of the ACRO New Practitioner Podcast. I'm excited to be joined today by my friend and colleague, Dr. Evan Thomas. Evan is the Chief Medical Officer and co-founder at the Renaissance Institute of Precision Oncology and Radiosurgery. He is an expert in stereotactic and functional radiosurgery, a clinical research leader, and an adjunct professor at the University of Miami Miller School of Medicine. Welcome, Evan. It's really great to have you on the podcast. Thanks for taking the time out and joining me here at ASTRO 2025.
Thank you so much for having me on the podcast. It's exciting. I've actually never done a podcast before, so this is my first one. I appreciate the invitation, and again, I'm excited to get into it with you.
All right, yeah. Well, we're honored to have you, and I wanted to start off kind of trying to get a sense of your story. I think that's something that's really important in understanding what drives us, and also what helps us find drive to push the needle forward. How did you get interested in functional radiosurgery?
Yeah, sure. So I really got interested in functional radiosurgery very early on in my training. I always had CNS mentors growing up, so to speak, in my rad-onc career, and naturally gravitated towards stereotactic radiosurgery as someone with a lot of CNS interest. And what appealed to me about functional radiosurgery in particular was that there's this storied, very effective treatment that we wield the tool for, but has kind of actually fallen out of use and favor in the community, leaving a lot of patients who can potentially reap significant benefit without access to it. And what further appealed to me was kind of the story of functional radiosurgery and how it fits into the history of radiosurgery in general. In that radiosurgery was actually invented for what we call functional applications. Long before we were even using CT scans or MRIs or able to even see tumors within the brain, people were using stereotactic coordinates to identify places within the brain that could be lesioned or treated to treat movement disorders, psychiatric disorders, and pain disorders.
Thank you for all of that context. It really does seem like this felt like an organic evolution from where you kind of started out with some really great mentors in CNS, and also this is something that's like been an integral part of the history of our field, and in a way it's kind of returning to our roots to now explore this more.
Absolutely. Yeah, and I think it's exciting to see the field really taking this re-interest in it and almost rediscovering something that's been lost. And I think part of that is also facilitated by the fantastic technology that we now have available. I mean, we have machines capable of delivering image-guided sub-millimeter precision therapy from all of the vendors' platforms functionally.
Yeah. And yeah, that's really exciting, and I think it's timed perfectly for this resurgence that we have this greater precision and greater image guidance than we have in the past. One thing now, you kind of spoke about some of the different indications earlier that we use this for. Could you tell me a little bit more about tremors specifically to kind of start off?
Sure. So I think essential tremor is probably, aside from trigeminal neuralgia, the most accessible manifestation of functional radiosurgery, and that's for a couple different reasons. The anatomy is relatively straightforward, and there's just a huge number of patients with this condition that are just out there, waiting to be treated because they've run out of efficaciousness from their medicines, and they don't want to get deep brain stimulation, which is we consider the gold standard procedure, but does require a craniotomy, does require a burr hole to be placed, requires patients to have a lead put in their brain connected to a battery that may or may not have to be replaced or recharged. So that's just not appealing to a lot of folks. And then procedurally, the only other option is MR-guided focused ultrasound, which requires you to get your head shaved, still requires you to be put in an invasive head frame. And the way that they deliver the lesion, essentially an array of sonicators, sonicator transducers shoot sound waves from all these different points across the skull that converge in one point, interface, intersect, and generate heat. But as all of those sonicators send sound waves across the skull, it actually cooks the marrow of the skull while it's happening, and it can be so painful that some people are unable to complete the procedure. And in fact, there's this parameter called the skull density ratio, where if your skull doesn't fall within a certain appropriate range, the neurosurgeons won't even try it on you because, again, literally, they will cook the marrow in your skull before they're able to deliver a therapeutic lesion. So again, definitely some downsides to that therapy too. But a ton of those are being done, and it's because patients don't realize that so much more comfortable, minimally invasive procedure exists for them.
Wow, yeah, there's definitely a lot involved, and there are a lot of options, and I think that this all speaks to the importance of interfacing with these other doctors, whether it be neurosurgeons or neurologists, and making ourselves known. And it seems like this is a fairly well-established indication, and one that's efficacious and minimally invasive, so it is kind of incumbent on us to try to be proactive about it and offer it to these patients who experience significant debility as a result of their tremor.
Yeah. So would it be helpful if I talk about how do you grow an essential tremor program?
Mm-hmm. Yeah, I definitely think so.
So let's kind of jump into that. I think, the most important thing is having good partners. And the good partners that you need for an essential tremor program are an experienced movement disorder neurologist and a neurosurgeon, preferably a functional neurosurgeon, but not necessarily required. And you need these people because it's the movement disorder neurologists that actually manage these patients and are the ones that screen them for who's appropriate and to make sure that they've actually seen appropriate medical therapy before we go down the procedural route. Mm-hmm. So there's 2 or 3 medicines that most patients will have at least tried. And these are medicines that I always ask my patients if they've tried. Propranolol, primidone, and topiramate is the other one. So once you've got your partners, you've got a neurologist that's makes sure they're medically refractory. Then it's patient screening. Really, who's a candidate for SRS? And I think the harder question is who's not a candidate for SRS, because really any patient, as long as they can get an MRI, can get and lay on a table for the amount of time, can get the treatment. We take people with coagulopathies that can't get DBS because they're on Coumadin or Xarelto or whatever, and they can't come off of that. But for radiosurgery, it's okay. It doesn't matter. People with brain atrophy that prevents them from getting deep brain stimulation, we're still able to find the area we need to target. That's not a contraindication. Prior surgery is not a contraindication. Again, people don't have to shave their heads. So I can't really think of a whole lot of people who haven't been candidates.
Okay.
So then the next aspect of the partnership is your neurosurgical collaborator. And you want a neurosurgical collaborator, not just because you're leaving a pretty significant billing code on the table if you don't have one, but the expertise of the neurosurgeon is very important. And as a field, this is historically their domain. So as radiation oncologists, we need to be cognizant of that and respectful of that. And we want to value their input and their expertise in helping us with target selection. Mm-hmm. And additionally, I have had some people who come for radiosurgery and then after having a discussion with me, end up deciding that maybe deep brain stimulation is better for them because fundamentally deep brain stimulation is adjustable. And sometimes people's tremor changes over time, and DBS can get faster, more total tremor. But for everyone else, SRS is a fantastic option. And so now you've built your partnership, right? You've got your movement disorder neurologist, you've got your neurosurgeon, and then ultimately your patients are going to come from the movement disorder neurologists and then the primary care people in your network. Probably the first few patients, it's good to cut your teeth with patients from the movement disorder neurologist before you start accepting direct referrals. Because the direct referrals, you need to make sure you're appropriately screening as well.
Right.
Now you've got your partnership. Do you have the equipment to be able to do the procedure? And what equipment do you need? Okay. You can get an ample MRI at many freestanding diagnostic facilities or hospital facilities. So that's not typically the barrier.
Right.
From a radiation delivery perspective, you need a piece of equipment that's really credentialed and appropriate for radiosurgery. You need something that is QA'd for less than 0.5 to 0.7 millimeter accuracy on your day-to-day Winston-Lutz testing. And my strong advice is for anyone doing this to have some form of intrafraction motion monitoring. And the solutions available for that are ExactTrack, or for instance, the ZAP has an onboard intrafraction KV imaging system. And then the other solutions are surface guidance or optical surface monitoring solutions. And on the Varian platform, that's Identify, and then there's a separate vendor, Vision RT, that also makes a very strong product. So, but you just need something to verify that your patient is stationary if you're going to be, especially if you're going to be doing this maskless. Okay, putting patients in a frame is always a viable option. There are frame adapters for almost all the couches if you and your neurosurgeon aren't comfortable doing frameless. But obviously, from a comfort perspective, patients are going to prefer frameless options, and that's how I'm doing all of mine now.
Okay.
So now you've established, you got your partnership, you've got your equipment. What imaging do you need? All of my patients, I want to see at least a volumetric thin slice MP RAGE and an F-Gator sequence.
Okay.
The F-Gator sequence is essentially a white matter nulled version of the MP RAGE, and it allows you to very clearly visualize the white matter tracks that appear in dark black. You want to be able to see that for two reasons. One, your dose limiting structure is the posterior limit of the internal capsule. If you inadvertently lesion that, your patients can and will have symptoms of a stroke, and obviously that's not what you want. There actually have been some high-profile lawsuits in the past because people were inappropriately placing dose into the internal capsule. So the other reason is because actually you can see surrogates of the white matter tracks that you're trying to treat on the F-Gator. So historically we call the target the ventral intermediate nucleus of the thalamus, but what we now know is that we really want to be interrupting signal along the dentato-rubrothalamic tract. And you can actually see some of its projections, the so-called rubral wing, on a high-quality F-Gator sequence, and there's good literature on visualizing that, particularly from Dr. Eric Middlebrook's group out of Mayo Jacksonville Radiology.
All right.
Okay. Now you got your team, you got your machine, you got your image. All right. Now you got to pick your immobilization. If you are going to do frameless, I really encourage you to be selective about the mask you use. The mask really does need to be stiff and tight and robust. There are some mask products out there that are probably more suitable for long course head and necks and shouldn't be used for high dose radiosurgery.
Right.
My shop's a Varian site, so we use the Encompass setup, which comes with the Q-Fix Fiberplast mask. So then the next step is the treatment planning. I think for most sites, you're going to probably be, if you're doing this on a linear accelerator, you're going to be doing this with cones. Mm-hmm. So obviously you'll need a cone setup.
Right.
And typically you use the smallest cone setting, which is, depending on the platform, a 4 or 5 millimeter cone. And then from there, it's basically cone planning. You're basically placing a shot. And your shot, there are stereotactic coordinate reference coordinates. I always start there, and then I adjust my target from the historical reference coordinates based on what I see on the MRI, or if I have good DTI, DTW, those sequences can be imported into fiber tracking software like BrainLab that can help you actually overlay those tracks. And then you want to make sure your dose in the internal capsule stays less than 26 gray. And from then, you and your neurosurgeon are ready to go.
Wow, thank you for walking us through all of that, from the process of patient selection to how you build a program by engaging with the appropriate other doctors like movement disorder specialists or functional neurosurgeons, or essentially a neurosurgeon who's comfortable being a part of this workflow. I think that that's all really helpful and practical, and I think that there's certainly a lot of settings where you can achieve this just by building the right team. Now, another area of functional radiosurgery that I think is of significant interest is the use of radiosurgery for psychiatric conditions. I know that the history of psychosurgery is there's some gravity to it. Do you have? Can you tell us a little bit about radiosurgery for psychiatric conditions and how one goes about addressing these conditions in the appropriate way with radiosurgery, and who some of the appropriate candidates might be?
Yeah, so this is a great question, and doing radiosurgery for psychiatric disorders, I would say, is definitely several orders of magnitude more difficult to implement as a program than essential tremor, and there are a lot of reasons for that. I think the most important of which is the one you were alluding to, which is the very complicated history of psychosurgery, not just radiosurgery, that really drapes us with a very large moral and ethical burden in how we deliver these treatments. Because in essence, when we deliver these treatments, we are doing something that's fundamentally altering a person's personality and aspects of consciousness and, in a sense, who they are.
Right.
And so when we do these treatments, and again, this is a much, much more niche application. We do this in a team of with not just a regular psychiatrist, but an interventional psychiatrist, and definitely a functional neurosurgeon. And the patient selection is very, very rigorous and very critical. These are patients, for instance, in the OCD space, whose OCD is so severe that they cannot function in what we call a normal life. They don't work, they have trouble leaving the house, their ritualistic behaviors may cause them chronic self-harm. So we quantify the severity of OCD on a scale called the Yale-Brown Obsessive Compulsive Score, or sometimes the FCI, the Florida Compulsiveness Index. And our threshold for being severe enough that we consider this treatment is really Yale Brown, or Y-box score, as it's sometimes called for short, of being over 30 to 33. And that severity, corresponds to the degree of symptoms that I was just alluding to. All these patients must have failed medical therapy, which is quite a few medications, and then most of the time they have either tried ECT or RTMS, which is repetitive transcranial magnetic stimulation. And they've probably been undergoing years of cognitive behavioral therapy. So all of those are prerequisites before you start thinking about offering a treatment for these. So, I would say the treatment of these is really reserved for, if you are in a community center, at least a community hospital with an infrastructure of all of those things, a very dedicated psychiatrist, and and a neurosurgeon with experience in the functional DBS space.
Thank you for walking us through all of that. It does seem that there's a lot of potential here to help out patients who have been refractory to a lot of other treatments, but you really need a team that is committed to ensure that not only the treatment is delivered in the appropriate fashion, but also that there's a strong follow-up and continued management to make sure that the patient lands safely, essentially.
Yeah. And, I think another aspect of this that makes treatment of OCD much more challenging is that, the response rates are good when the procedure is done right. 30 to 60% of people can have, greater than 50% improvement in their Yale Brown score. But they're not as good as essential tremor. And in essential tremor, the response rates we're quoting people are, 80% of people are getting 60 to 75% reduction in the tremor in the extremity that we're treating. Additionally, when properly targeted, the essential tremor patients respond in 2 to 4 months. The OCD patients, if they respond, it's more on the 6 to 12 month space. And as they're responding, they can have transient shifts in the severity of their psychiatric symptoms, which can also be challenging to manage.
So that, while there is opportunity to help them significantly, what I'm hearing is that, again, it's important to just be very thoughtful about how we go about this and make sure that they have the appropriate support at every step of the way.
Yep, absolutely. And, we didn't talk about it before, but the dose we use for obsessive compulsive disorder is significantly higher. Historically, people use doses as high as 200 gray bilaterally to the ventral or the anterior capsule. Most of us don't go that high now. Those of us who do this are usually in the 150 to 160 point max. The targeting is also trickier for this. We talk about just doing the internal limb of the capsule, but you scroll through an MRI, the anterior limb of the internal capsule is actually pretty large, and kind of sits in a fairly elongated column, and you're not ablating all of that. You're trying to interrupt one of a large number of circuits that run through there. And so being able to pinpoint that very specific circuit is also critical, and we use tractography typically to do that now. The pathway we target is called the hyperdirect pathway that connects the orbital frontal component of the prefrontal cortex to to the rest of the brain via the thalamus.
The role of tractography is definitely something that's really critical, is what I've realized, in terms of just making sure that we're targeting exactly what we want and sparing the healthy brain additional dose. Can you kind of speak to some of the strategies you use to manage radiation necrosis when it happens?
Yeah, I think management of radiation necrosis is a really fundamental array of tools to have in your belt if you do CNS radiosurgery, whether it's functional or treatment of other tumors, brain mets, etc. So my strategy, at least in the first step, is not dissimilar from, I think, most practitioners, in that we typically start out with a trial of a taper of corticosteroids. Most of us in the CNS space choose dexamethasone, not only because that's just what everyone uses in neurosurgery, but because it has the lowest ratio of a mineralocorticoid component effect to anti-inflammatory effect. And it additionally has a nice long half-life. Its half-life is 36 to 54 hours. So another thing a lot of people don't realize is you don't need to do QID dosage. You can usually get away with BID dosage and have the same pharmacokinetic profile. For your inpatients, that also keeps the nurses from waking up in the middle of the night 2 extra times. But anyway, I typically start people out with severe radionecrosis at 8 milligrams BID, and then adjust their tapering profile from there. I never go from high to low dose by more than half with less than a week of taper. So it might be something like 8 milligrams BID for 1 to 2 weeks, then 4 milligrams BID for 1 to 2 weeks, then 4 milligrams until the next MRI. And then we see what the next MRI looks like. More recently, a lot of us are integrating the use of the herbal supplement Boswellia serrata into our management, and the Ohio State group has published some really nice papers on that. You can go look those up and see just how many people have significant response rates to Boswellia. So nowadays, I'm actually using this as an adjunct or sometimes my primary treatment for radionecrosis. For severe cases, still start with steroids, but can go ahead and add on Boswellia. The dose that was utilized in the trial that established the role of Boswellia was, I believe, 1,500 milligrams 3 times a day.
Okay.
In reality, a lot of patients don't like taking herbal supplements 3 times a day. I have found that going to a little higher dosage and doing it twice a day can still be effective. So I use 2,400 milligrams twice a day on most of my patients. You need to be able to make sure you recommend them to a formulation of it that is well vetted and has good purity, because like any other nutraceutical, it's a really mixed bag out there on the quality of these. And even if you use the same brand, sometimes you'll notice they start using different suppliers, or different batches have different efficacy. So you got to pay attention. So then after, if those don't work, then we've kind of got to pick from a couple of not as attractive options. I typically offer patients either one of these. Hyperbaric oxygen is technically the less invasive route, but it is covered by Medicare and insurance. But it does require anywhere from 3 to 6 weeks of daily or twice daily treatments, or dives as they call them. And sometimes a disadvantage of it is that actually this hyperoxemic environment can be pro-neuroexcitatory, which in patients who have had seizures or on seizure medicines can actually uncover seizures. So if they don't want hyperbaric oxygen, or they're not a great candidate because of seizure activity and so forth, then the next mainstay option is to send them to your neuro-oncologist or your medical oncologist for Avastin treatment.
Okay.
And Avastin treatment for radionecrosis is half the dose that's used in the ovarian and colon cancer chemo regimens that are typically used, 5 to 7.5 milligrams per meter squared, given every 2 weeks. And usually you do 2 or 3 cycles and then see what the MRI looks like. Most people have pretty good response to that.
Okay.
That failing, then you're calling your neurosurgeon friends and you're asking them to consider either lit or sometimes going in and doing an open resection of the radiosurgery. That's kind of how I think of, that's my paradigm of management for radionecrosis.
Thank you. That was a really helpful primer, I think, both in terms of the global overview of how you manage radiation necrosis and also how the management differs for these situations versus oncologic indications. And related to that, can you talk about the concept of hyper-responders? And because I know that not everyone experiences radiation necrosis after doing this treatment, despite the dose being as high as it is, but some patients are predisposed to it.
Yeah. So the concept of hyper response is a very interesting one, and something we've been talking about in small circles of the CNS community for a while. But if you go put in Google Scholar hyper response in radiosurgery, you're actually not going to find anything. And so it's not an official term. But what the term refers to is as you mentioned, when you see a patient having a more extreme response to the exact same size of lesion or tumor treatment that someone else gets that doesn't have this significant response. And when radionecrosis happens, we typically see it in the 4 to 12 month window after a radiosurgical treatment, and it's typically preceded by a small area of contrast enhancement. Some people call it RICE, or radiation-induced contrast effect. There's some other names for it, with a surrounding rim of perilesional edema. And usually that rim of perilesional edema is much larger than the focus of enhancement. And then what typically happens is that enhancement continues to grow, becomes cystic, the inflammation around the perilesional vasogenic edema grows, and essentially just keeps getting bigger until you do something to stop it. So the reason I like the term hyper-response is because it can allow you to identify and label patients before they're actually in the radionecrosis stage. So if you see someone who's having more contrast enhancement and more edema than you would expect at that time point, in my mind, those are someone I'm worried about being a hyper-responder, and I'd rather intervene before it turns into fulminant radionecrosis rather than trying to treat it after the fact. We think that this is likely a combination of some genetic predisposition along with environmental factors. There are some hypotheses that it's related to microbiome. There are some hypotheses that it's related to metabolic factors. We know that diabetics are slightly higher risk of having it and so forth. But if you ask me up front, who's gonna get radionecrosis between two people who get the exact same size lesion in the exact same place, I can give you their risk numbers based on V12 and so forth, but I can't tell you which of two people getting the same thing is going to be the one getting it. I think the rates I quote to patients are between 1% and 5% of people are at risk for this, and it's something that I counsel everyone about when I do any kind of radiosurgery.
Thanks for discussing that. I think that that's really helpful because it is, this is the case for any sort of radiosurgery you do or any radiation that you give. Some individuals will be more predisposed to having certain toxicity, while others will not for the same dose.
Yeah, and I think it's worth pointing out that the GU community is doing a particularly good job at really looking at biomarkers to predict who's at risk for elevated toxicity profiles when they're getting prostate or bladder radiation and so forth. And that's something maybe we as a CNS community should be taking some guidance from.
Yeah, I think that cross-disciplinary talk is always really helpful because you see the same themes kind of repeat themselves across different lines or subdivisions. Another area of functional radiosurgery that I think would be helpful to talk about, kind of on the other side of things from radiation for psychiatric conditions, is its use for chronic pain. Trigeminal neuralgia has been a long-standing indication, for example, and I know as well that it's been used for cancer pain. Can you kind of talk more about this facet of things?
Sure. So, I think we can start out with kind of the most historical approach to treating cancer pain, and it's actually a very fascinating story. So in the early 50s, there were a couple of neurosurgeons, very well-known neurosurgeons, one named Dr. Olive Krona, and the second, his name is escaping me at the moment. But we're looking for ways to arrest the growth of hormonally driven tumor in hormone-sensitive cancers, namely breast and prostate cancer. Mm-hmm. Now, in the early 50s, if you go back, we didn't have tamoxifen, we didn't have androgen deprivation therapy, so these people just essentially, if they were refractory to standard chemo, which, as we know about these hormonally driven cancers, a lot of them are, there really wasn't anything good to do. So this team thought, well, what if we go to the root cause of the secretion of these hormones and we address it there? So they took a series of 8 to 10 patients, I think, and performed a surgical hypophysectomy, or literally removal of the neurohypophysis or the pituitary gland, to see if it would arrest the growth of these tumors. And as you might expect, the patients experienced an array of endocrine side effects, rip-roaring diabetes insipidus and SIADH and so forth. And unfortunately, they did not have improvement in the progression of their metastases. But what was interestingly noted in that almost every one of the patients, they had immediate pain relief. Mm-hmm. And so this prompted interest in this mechanism of pain relief, and people began looking at other ways of doing this procedure, the so-called hypophysectomy. Mm-hmm. People looked at doing it with RF ablation, or doing it chemically by injecting glycerol or ethanol or phenol into the sella turcica to chemically ablate it. What they ultimately learned was all of these chemical and surgical approaches did have pretty good effect at pain relief, but still caused this same really problematic endocrine side effect profile. Mm-hmm. So in 1972, the first instance of using a gamma knife to do this was published, and there was a small series of single-digit number of patients, I think on the old Model U gamma knife at that point. But it was applied for these people, and the original dose was actually 250 gray. And this was all X-ray based planning, no MRI, no CT scan, just X-ray and stereotaxy based planning. So it really kind of makes you think like how much braver these guys were back in 50 years ago than we are now, and the doses they were using that are scary even to me.
Right.
They did learn that it was still effective to do it with the gamma knife treatment, and the people still got very quick pain relief, usually in 24 to 72 hours a week. And so that prompted a multi-institutional collaboration, and there was a study published in 2002, a collaboration between several of the gamma knife groups, including the group out of Marseille and the group in Tokyo, that again confirmed this procedure's effectiveness. But again, still not that many patients getting the treatment. And it's only recently in the last 5 to 10 years kind of come back in vogue. And I think a lot of it has to do with the fact that now we have these large inpatient cancer hospitals where you have cancer patients with advanced cancer being managed by dedicated pain teams who happen to also be in centers that have access to a radiosurgical tool that can deliver this treatment. Mm-hmm. So these centers really are conducive to being able to do it, because the appropriate patient for this treatment is someone end of life, going to hospice, and you're trying to relieve their pain, let them go home and pass in dignity and comfort with friends and family, and not languish away on IV pain medications until they pass. Mm-hmm. So for that, it's really effective, and the doses that we now know we need to use are much less than that 250 gray I mentioned. I use more like 150 to 160 gray point D max on a gamma knife. If I'm doing these on a linear accelerator, then I'm prescribing to a volume rather than a point, and I might do something like 80 gray with just, optimal fall off and for all the OARs. For this one, your two OARs are, of course, the optic apparatus and the brainstem. And for minimal risk, we try and keep the optic dose less than 8, but accept less than 10 if we can get it. In reality, most of these people aren't going to live long enough to develop an optic neuropathy, mm-hmm. But still, as a general practice of good radiosurgery, you should be respecting those constraints.
Right.
More recently, the group in El Salvador has been pairing this treatment with a bilateral centromedian thalamotomy and a so-called triple target pain approach, and has published some very promising data. And the great thing about this is the doses they're able to use with this triple target approach are actually much less than what we standardly use. So we think it's a safer approach to do it too. And so that works out of by Dr. Eduardo Lobo's group. So I encourage you to check that out and read his papers. He almost exclusively publishes in open access journals, so they're available for everyone to read.
That's really great, and I think that it's interesting, again, to note the theme that this is something that we've been doing for a while, and now we're seeing it come back up, and I think it really is incumbent on us to incorporate this into our arsenal for particularly patients who need palliation. This is another way to kind of approach it, and really exciting to see that there's to see the work that Dr. Lobo is doing that is making it both safer and more efficacious. So yeah, thank you for walking us through all of that. And one last area of functional that I would love to hear your insight on is the use of radiosurgery for epilepsy. I know that this has taken off recently, particularly with higher quality MRIs. So I was wondering if you could speak to this, and also how some of the advantages that radiosurgery offers over surgery.
Yeah, sure. So this is, again, in keeping with the central theme we're espousing of old treatments made new again. Radiosurgery for epilepsy has been around for a long time, and it's historically been used mostly for mesial temporal lobe epilepsy, with the target being the anterior temporal lobe. It was studied in a randomized clinical trial called the ROSE trial, being compared to surgical resection, or an ATL, anterior temporal lobectomy surgery. And it's an interesting trial to go back and read, because depending on the specialty of the person reading the trial, they'll read it more favorably towards their specialty. So when I read that trial, I think that the outcomes are more favorable for radiosurgery, particularly in terms of the side effect profile, the only downside being the latency to effect. The surgeons, the surgery arm, did have significantly higher adverse effects, but the time to be seizure-free was reached much more quickly. So it just kind of really speaks into questions of how we all interpret trials from different fields and different perspectives. But I think really the best takeaway from that trial is that both are pretty effective treatments, and that there are definitely appropriate patients for either intervention. What we've started doing much more often now is using radiosurgery for focal epilepsies. Although mesial temporal lobe epilepsy really is a focal epilepsy, it's a very storied classic one. But there are a whole mixed bag of epilepsies that are associated with minute cortical dysplasias that people have as a result of head injuries or microstrokes, or sometimes just aberrant patterns of embryological development. And these tiny cortical dysplasias, almost like cardiac myocytes out of place beating at the wrong rate, can lead to arrhythmias. These foci in the brain become epileptogenic, and their signals can cascade over, resulting in partial seizures that sometimes generalize. And in the early days of MRI, low field MRIs, we were never able to see those. But as we've gotten higher and higher quality 3T and now 7T MRIs, we're able to pick up these really subtle cortical dysplasias. And typically the next step is we see that, and then the surgeon goes and then they cut it out. But if that cortical dysplasia is in a very eloquent territory, there might be a better treatment.
Right.
Enter radiosurgery. And I think this is a very accessible component of functional radiosurgery, provided you build that bridge with the epilepsy team and you make them aware that this treatment is offered. Obviously, it's radiosurgery. You still want a neurosurgeon involved, but the doses we're using here are 25 gray in a single fraction, doses that most people are comfortable with from their days of treating AVMs or functional pituitary adenomas and so forth.
Right.
So, and it's unlike the other components of functional surgery. There's something you can see and target and contour and draw a GTV around and make a nice little PTV expansion if you want to, and you're treating it like the other things we do in radiation oncology. So for that reason, I think that's a really attractive element of functional radiosurgery for people to slowly wade into if they want to get into it.
Yeah, it sounds like this is kind of a perfect area for us to intervene and help patients who, in a non-invasive fashion, who may differ from the typical patient we see, but we're with this able to help them in a significant way. Thank you for breaking down these various different areas of functional radiosurgery and how we manage them and how we can kind of build programs in them, and also some of the things to watch out for as we go about that. I think that an important part of why we're doing this podcast, and I think of our work here at the various different radiation oncology societies, is how can we engage our community of radiation oncologists. So I was wondering if you could speak to what you think that we need to do as a collective. I know that advocacy is important in making this type of treatment sustainable. Can you kind of speak to what would be good for a typical radiation oncologist out there in the community or at an academic medical center to do to get involved?
Yeah, well, I think like any other aspect of, and I'm not going to say radiation oncology because we're not talking about oncology here, like any other aspect of radiation medicine, it's important to be an advocate for your tools and your field to the other referring providers and make them aware of what you and your treatments have to offer them. Just like, we have to go to a liver tumor board and fight our IR colleagues to be able to give SBRT to patients in favor of RF ablation when we know it's vastly superior for local control. Sometimes you got to go into other specialties boards, whether it's a movement disorder board or an epilepsy board, and be an advocate for your field. Now, maybe you don't have to dunk on them as hard as we need to dunk on the liver IR guys sometimes, but again, the theme is be involved in the places where those decisions are being made. They're not just going to send you patients for the hell of it. They want to get to know you. They want to know that you're a capable physician and that you're going to take appropriate care of the patients that they're going to send to you. They probably want to, walk through cases with you, see that you've shadowed or proctored with someone who's done some of these. But once you do a few and you make their lives easier in managing their patients and help their patients, they'll start sending you lots of patients. Also I think be an advocate for these tools, as a field. Some of these treatments are in the Medicare LCDs for medical appropriateness, and you have no trouble getting things covered. Some of these other treatments are not listed as explicit things and are tougher. So just, be advocates for the field, in your societies, in your payers. If you're interacting with, decision makers, keep them aware of the good things that you can do with these treatments.
Thank you for outlining all of that, and I definitely do echo the need to think of ourselves as radiation medicine doctors. I think that's a critical shift with engaging in these different areas, and in addition to our role as a radiation oncologist, so to speak. And I think as far as advocacy, I know that there are several different ways to get involved with that. So there's ASTRO Advocacy Day, there's ACRO Advocacy Day, and also obviously working together with these other specialties to essentially mobilize in pursuit of this common goal of helping our patients and making sure that these practices are sustainable over time. And one thing that I was wondering if you could speak to is, how do you do this appropriately in low resource settings of functional radiosurgery?
Sure. So, I think there's a great example. There's several great examples of programs that are offering high quality movement disorder functional radiosurgery programs in community settings. I'm hesitant to use the term low resource because at least everywhere in the U.S., we're not low resource compared to the rest of the world. But for instance, Dr. Diane Heaton, who I recently had a conversation with us about this, is offering these treatments on her CyberKnife in rural eastern Oklahoma in partnership with a neurosurgeon and starting to build a program there. There's a community program in Washington State that's treated, I think, over 100 patients total on their linear accelerator with cones. So these are definitely programs that can be built out in the community. And again, the recipe is there. Meet and network with your referring physicians, build the program, build confidence in the referring docs, and then do great treatments. The patients will come.
Thank you. I really appreciate how you provided examples of how if you build the right team and you work together, that you can essentially provide high quality treatments. Now, the last thing I was wondering if you could speak to is new directions or future directions in functional radiosurgery and how you see things kind of evolving.
Yeah, sure thing. So, I think it's a really exciting time as we have interest increasing in this, not just within the CNS community, but within everyone in the radiation community. And the thing about functional is that for a lot of these treatments, we have a roadmap already laid out by a lot of the functional neurosurgery community and targets that they've experimented with DBS or RF ablation with. I'll use OCD as an example. There's plenty of OCD literature for DBS, but the DBS just hasn't worked out that great for these patients, which is why, the program I previously worked with at Ohio State, the neurosurgeon and the interventional psychologist preferred to send these patients to radiosurgery over deep brain stimulation. So I think there are going to be lots of other targets that come up, and there are plenty available in the literature now that are ripe for us to try out and run clinical trials for radiosurgery with. I think one thing that's incumbent on us as a field, like everything else we do, is for these new indications, we need to be accumulating data in a controlled and structured manner, particularly in the early stages while we're collecting case data to build the justification for trials, and then we gotta run the trials. And then ultimately, it's the clinical trials that convince the payers that there's value in these treatments and that allow us to be able to provide them for the treatments. I think one exciting one, I know the team at UCLA is working on a clinical trial for SRS for addiction. There are some others of us looking at clinical trials for SRS for a different movement disorder called spasticity in patients with cerebral palsy and spinal cord injury. And then there are some other targets we're looking at for conditions like tinnitus and PTSD as well. So hopefully lots of exciting things ahead, and hopefully everyone will see more and more indications for radiation coming out.
Well, thank you so much for giving us that look ahead in terms of what we will see in the coming years in radiosurgery. I also wanted to encourage everyone to check out not only what we do here at ACRO, but also the Radiosurgery Society and the International Society for Stereotactic Radiosurgery. Evan and I have been part of the Radiosurgery Society and its functional radiosurgery working group. So there's a lot of discussion going on throughout the year and also at that annual meeting on where we're going with radiosurgery. So, Evan, thank you so much for taking the time out. Really enjoyed hearing your talks throughout ASTRO and also having this chance to sit down with you to talk about things in a bit more detail in a way that will be helpful to our listeners. Thanks so much.
Yeah, it's my pleasure being on. Thanks for having me, and always a pleasure to see you, my friend.